Good morning, everyone. Welcome to our Informs MIF 2025 Summer Webinar Competition. We are going to start shortly. In the meantime, I invite all of you to scan the QR code and it will give you a chance to give feedback to all of our participants today and give us also feedback on this event. And I see that we do have a sizable amount of participants now, so let us get started. Today we have 9 wonderful PhD students with us presenting their research. We have Drusi Wei, Pedro Chumpitas Flores, Naushin Sharmile, Rashik Sidiki, apologize my mispronunciation, Enoch Bonsu, Yanang Shu, Valentina Castañeda Torres, Guanling Yang, and Kimia Mohanari Josani. Again, for those of you who just joined us, please go ahead and scan the QR code that you're seeing on our screen. This will give everyone a chance to give feedback to all of our participants and give feedback as well to this event we're organizing. And in the meantime, I want to explain everyone how this session will go. We'll have each of the participants have 5 minutes to present the research, and we'll have 2 minutes for Q&A. You can you please confirm that you guys are hearing me, just to make sure?
We are.
Yes, I believe. Perfect. Thank you very much. You guys can type in your questions in the chat, or I don't know if participants can unmute themselves, probably not. So please just submit your questions in the chat. We'll be monitoring that and answering your questions as long as we have time within those 2 minutes. For our participants and everyone who is attending, we'll be very strict with the time management. So at the 5-minute mark, I'll be interrupting the presenters if they haven't finalized their presentation. So please do not take this as disrespectful. I just want to make sure that everyone has the same amount of time to present their research. I will now start with everyone's slides, and as each speaker moves forward with the presentation, we will be doing a short introduction. So let's see. We first have with us Rusi Wei. Rusi is a PhD student at Drexel University, and her research mainly focuses on privacy preservation in structured data and exploring the trade-offs between data privacy and utility. And Juicy, the floor is yours. Please make sure your microphone is unmuted, and I'm going to give you control right now. We're all yours.
Okay. I think, can you hear me?
Yes, we can hear you.
Okay, so I guess I can start it?
Yes.
Okay. Hello, everyone. I'm Yusuf. Thank you for the invitation and having me today. So let's get started. Today, I'm going to talk about healthcare data and the privacy. Healthcare data is one of the most powerful assets we can use to improve patient care. It enables machine learning models to predict disease patterns, identify conditions like early stage of sepsis, or optimize treatment. That's why hospitals share data with researchers. But sharing healthcare data also introduces privacy risk. The number of individuals affected by healthcare data breaches has skyrocketed, reaching over 300 million in 2024 alone. So while researchers need high quality, comprehensive data to build models that are actually useful, at the same time, hospitals have legal and ethical responsibilities to protect patients' privacy. So, responsible data sharing means balancing both privacy and utility. Now, how can we make responsible data sharing? This is the challenge our research addresses. We use real-world healthcare data set of patients hospitalized between 2013 and 2015 to build machine learning models that predict whether a patient has sepsis at admission or it developed during their hospital stay. The dataset includes demographic and healthcare utilization variables. Here's how we approach the problem. First, we identify which patients are most vulnerable to privacy attacks. Next, we evaluate how important these patients are to machine learning models for predicting sepsis. And finally, we apply our anonymization model to protect them and evaluate how it protects privacy and preserves machine learning performance. Let me walk you through each step. First, we identify which groups in the dataset are more vulnerable to privacy attacks. We found that vulnerability is not distributed evenly. Certain populations face significantly higher privacy risks. For example, patients who stay in hospital longer or have more frequent visits are much more likely to be at risk of privacy attack. We also see differences across demographic lines. Black, Hispanic, or Latinos patients are more vulnerable than others. These disparities raise an important question. Are the groups most at risk of privacy attack also essential for machine learning? In fact, you can see that the vulnerable population here is actually more likely to be diagnosed with sepsis. So if we take out this subpopulation from model training, the precision drops. Excluding a vulnerable population to enhance privacy protection comes at the cost of reduced model accuracy. Therefore, we should not remove their information to keep the data secure. Now the problem moves to how to protect the vulnerable population while preserving machine learning performance. We propose our anonymization model. Our model is a customized clustering approach that makes sure the clusters are big enough and are not too uniform so that it cannot identify individual patients from the original data. Here are the results. Our model protects 90% of vulnerable patients while maintaining machine learning performance nearly as high as the original data. To conclude, our study finds that older adults, high hospital utilizers, and the minority groups that most vulnerable to privacy attacks. And excluding them harms machine learning performance. To support responsible data sharing, hospitals should use our anonymization model and share the resulting anonymized dataset with researchers. Our method offers strong protection for vulnerable patients while largely preserving machine learning performance. Thank you so much. Any questions?
Thank you, Juicy. Let me go back to control the slides. And at this point, we welcome questions from the audience. So feel free to add them to the chat. We still have around 2 minutes. And while we get questions from the audience, I also want to invite the rest of the participants to ask any questions. You can actually unmute yourselves if you do have any questions. But in the meantime, while questions come in, Juicy, I wanted to ask you, how transferable is your model to other fields or to other areas outside of healthcare?
Oh, actually, when we proposed the model, we tried different data set like finance and some other types of data set. It's not including the healthcare, only for healthcare data. So if the data set is structured, it's you're welcome to use. They're pretty much for all types of structured data set.
Wonderful, thank you.
We also have a question from the audience about the definition
Oh, thank you.
of vulnerability. Can you, Yusi, can you expand a little more? What exactly does it mean to be vulnerable within a population?
Oh, the vulnerable means based on the literature, we find there are two typical privacy attack. The name or linkage attack and a homogeneity attack. So vulnerable means once we, based on the definition of privacy attacks, we found okay, these some of patients are at the risk of these two types of privacy attacks, and then we call it vulnerable patients.
Thank you.
Wonderful, thank you. Okay, this is our time for Juicy. We now welcome our next speaker. And hold on, Juicy, again, I haven't removed your control. And perfect. We now have, oops, sorry about that. I'm sorry, one second. There you go. We now have Pedro with us. Pedro, can you please unmute yourself and make sure that you have access?
Sure.
Perfect. There you go. Okay, giving you access now. So, well, one second. Okay, perfect. I think you can see the screen, right?
Yes.
Perfect. Pedro, we have Pedro, PhD student in the University of South Florida. His research mainly focuses on global optimization methods for large-scale machine learning training and decision-making under uncertainty. And Pedro, the floor is all yours.
Thank you. Well, hi, everybody. My name is Pedro. I'm a PhD student at the University of South Florida. And I'm going to first talk about constraint clustering, but in large scale. Let me first introduce actually how this problem is formulated. We start like a k-means, like a data set and a fixed number of clusters with two types of constraints. A masking constraint, that means that 2 points has to be together in the same cluster, and cannot link. That means that 2 points have to be different in different clusters. Our goal is to choose k cluster centers and binary assignments that respects all mask links and cannot link constraints by minimizing the total within cluster square distance. Exact clustering problems are NP hard, even for 2 groups or 2 dimensions, and constraint clustering is no exception to that rule. Well, we can formulate this actually as a mixed internet theorem, which is the formulation here. And let's talk about actually what were the previous records. Like right now, the record is around 800 points. And we have achieved a global optimization of 200,000 points in cannot-link case and 1.5 million points in must-link case, which we're talking about 200 times the state of the art, enabling the first time exact constraint clustering at large scale. But how we have done it? We have combined 2 ideas. First, we have explored only the space of cluster centers by branching only a reduced space so that our algorithm will converge, is because this algorithm actually has been previously proved actually for the k-means problem. Second, we have introduced a central-based pseudo points, which will provide a fast and explicit lower bound and completely avoid heavy optimization subroutines. And finally, we have applied geometric bound techniques to deal actually with cannot link and also extend it to masking. The branch and bound idea is quite simple. We have actually defined a search region with the smallest bounding box containing all the central candidates. As we can see here, the black boxes in the figure, and then we split that box along with one central coordinate at a time, creating a smaller subregions. In this way, we only branch k times n variables instead of every assignment. Then, for the cannot link and also extend it to the mask link, we can apply some geometric sample determination rules. First, with error elimination. If the minimum possible distance for a sample to any point in the region exceeds the current best cost threshold, we know that that sample can never belong to that region. So we can set actually the assignment to 0. Next, we can force assignment whenever the worst distance in one region is strictly lower than the best distance in all others. We can fix the example to that region immediately, as we can see in the first case. Then We can also talk about a constraint propagation, where we can use canonical constraint to discard any regions that would violate those rules and carry force assignments across mass link points. And that's how actually we can combine these two techniques. Then for the pseudo points, we have something called actually mass links, which we can represent it actually with an equivalent constraint one problem. In this case, a simple k-means. For each group, take points of the mass be together so that we can compute each center and replace the original points by t identical pseudo points. So technically, we're collapsing these samples into one pseudo point. And this substitution will only add a group internal variance into the objective so that the global minima will remain unchanged. And finally, for the lower bound and the upper bound, for the lower bound, we can partition the data into G blocks with adjacent group centers at the same, and relaxing a couple of constraints with non-negative multipliers, which will yield a Lagrangian whose value is a lower bound on the not objective. We tighten that bound by updating this multiplier with only a handful of small interprogramming second order solves will be quite minimal. And for the upper bounds, actually, the strategy is quite simple. We can actually apply a k-coloring bound, which will actually have a pool of upper bounds where we can select actually which one will not violate any of the pairs. And for the mass link, we can do actually a simple trivial upper bound, which is trivial k-means. Now, let's talk about the results. Our methods, we have tested around actually 100 to 200,000 points. Combined canonical link and both mass link and canonical link, we can handle around 200 points, 200 times actually the state of the art. And for the mass link case is where actually we can reach actually around 1.5 million. And yes, actually, well, sorry if I have some problems with the controller. It seems that it's, yeah, thank you. Well, the conclusion is basically actually that we have reached the first deterministic solver. It's an unprecedented scale, and some limitation is still actually with the canonical link. Well, thank you very much. I know you have any questions.
Thank you, Pedro. Thank you. Let me check.
I can ask a question if there are
Thank you very
no
much.
volunteers. Can you tell us more about very cool stuff, by the way? Can you tell us more about the implications of tightening the bounds? Like how bad were the bounds before? And are the bounds now, is the improvement practically meaningful compared to what you have observed before?
Yeah, indeed. Actually, the k-means problem has different actually local minimums. So, for example, if you change actually a simple seed for the k-means, you will reach actually a minima, and there will be perhaps in the high dimensions could be actually quite dramatically. We're talking about improvement around 2–10%, could vary actually depending on the case. In the canonical link mass link case, that is the was constraint clustering problem, it's actually even more difficult because a simple actual iteration of the k-means, that is the heuristic for this problem actually, even sometimes cannot reach actually a feasible solution because we'll iterate actually in different centers, like a pool of centers, and many times actually will not find actually a center that will satisfy all these points. That's why we have to see it as an optimization problem. So actually it's a double thing. First is that, for example, in previous cases, as state-of-the-art specialty that reached actually 800 points, it's quite significant because previously even an heuristic had problem with that. And now actually we are scaling that band for around 1,000 times, or 200,000 for canonical link and 1,000 for mass link.
Gotcha. Okay. Well, wonderful. Thank you.
Thank you very much, Pedro. And with that, we've come up to the end of your time. We will now move to Noshin Sharmail. Noshin, please, while I introduce you, go ahead and unmute yourself. So I'm going to give you control in a second. Noshin is a PhD student at North Carolina Agricultural and Technical State University, and her research mainly focuses on supply chain and humanitarian logistics with an emphasis on charitable food distribution operations. And her work integrates nutrition considerations into food distribution systems to enhance efficiency and equity. And with that, I will give you the baton. So Northwind, we're all yours.
Hello everyone. So my research is mainly based on food banks and food insecurity. So 13.5% of US households struggle with food insecurity in 2023. And according to Feeding America, 53 million people visited food banks in 2021. However, only 25% of the food that are distributed by the food banks are like shelf-stable food, which are not very nutritious. So to encourage the food to be more nutritious, we have HER guidelines, which basically ranks the food into 3 categories: red, yellow, and green, with red being like the least nutritious and green being the most nutritious food. And I talked about working with food banks. And so this particular case, I'm working with Food Bank of Eastern and Central North Carolina, which serves in like 34 counties. They have 6 distribution centers and over 800 partner agencies. So for this research, my data sources are like map the meal gap data from Feeding America and distribution data from Food Bank ABCNC from July 2021. So basically in this research, we're trying to understand what is the current distribution pattern is, how equitable or fair this is right now, and what the measures that I've been proposing, how good they actually are with the fairness matrix. So exploring the data, we can see that their highest served counties in terms of pounds are Johnston County and Wake County. And they are also the ones getting most amount of nutritious food in terms of pounds, as shown by the color green. However, when we take a look at the food insecure population data in efficiency counties, we can see that Wake County actually has highest amount of food insecure people with 94,000, and Jones County and Johnston County are like on the lower end with only 1,500 for Jones County. So considering these factors, we can see that Wake County is actually really underserved in terms of pounds, and Jones County is overserved. Although they are not getting more food in terms of pounds, they are overserved due to having less food insecure people in there. We can see the same pattern emerging in terms of nutrition as well, with green food and red food as well. So considering this, we built a nutrition linear programming model, and we basically evaluate on 2 cases: nutrition-based fairness matrix and weight-based fairness matrix. Which nutrition-based metric focuses more on what agency's serving capacity of a nutrition type is, which focuses on quality rather than just quantity. And for agency weight-based ones, it just focuses on the volume of the food that's going to the agencies. As for county level metrics, we are just adding out the agencies that are in the county and their serving capacities in there. So when the model focuses on more nutrition focused metrics, we can see that since agencies have heterogeneous demand for each type of food, everyone is getting same proportion of what they want, but when in terms of pounds, they are not met equally, with someone only getting 50% of the food that they want, with another one is getting like of all of their capacity met. This approach, what happens is, this approach leads to like less variability. I mean, this doesn't make the counties more overserved. It just reduces the bounds of being overserved and underserved. But also this approach leads to waste, which leads to our second approach, which is like balanced focus, which takes the weight-based focus first and then tries to make it more nutritionally equitable. And we can see that in this case, the nutrition requirements met are like all over the place. However, in this case, we can see that all agencies are at least getting their serving capacity in terms of pound is being met here. And this approach also leads to like, it has more variable than the nutrition focused approach. However, this approach also leads to like no waste in the system as well. So we can see that our models reduces the variability, but it's also still less, I mean, it's still inequitable. So in this case, we need to add like expand and add more partner agencies to boost capacity in the underserved regions. And combining both of these metrics that we proposed, we can serve food more equitably in the underserved communities. Thank you.
Thank you very much. We now welcome, hold on one second. We now welcome questions from the audience. So I do have a question for you. You mentioned the model still needing additional details to be able to balance that trade-off between waste and overproduction. And I'm just curious, how do you see the way moving forward to be able to tackle this challenge you're currently having with the model?
So which is why we move to like a balanced optimization model, like meeting the weight-based because in this system, we don't want any waste. So we are focusing more on the weight first and then trying to make it like more nutritious, focusing on, basically we're trying to make the pounds more nutritious, if that makes sense to you. Which is why we've moved to the second model as well.
Would you eventually, as you move to a more nutritious focused objective, would you eventually accept some kind of waste? I'm just curious if there's actually a way to mitigate both things, to increase nutrition but also minimize waste. Seems like they are
So
always
in
going to
this,
be opposing objectives.
So in our network, we don't want any waste. So for our models, it has to be the top priority, which wasn't the case for the first model. In the second case, we make our models in a way that it first focuses on making sure there's no waste at all. Then it focuses on making it as nutritious as possible in that context.
Perfect. Thank you very much. Okay, we're going to move forward to our next speaker. And we have Rashik Siddiqui. Rashik, please go ahead and unmute yourself while I introduce yourself and give you control. Rashik is a PhD student at North Carolina State University, and his research relates to food insecurity as well. So we'll continue talking about food insecurity, food access, and cooperative food bank operations. Rashik, the floor is yours. Perfect. Yes, the floor is yours.
Okay, so hello everyone. So our work has been focused on the access to food support in the food bank network and identifying the gaps. And our work has been funded by NSF here. And to talk more about food access, let's go here.
I don't think we can hear the video, Rachid, just as a heads up.
Oh, okay. I'm sorry. So here the speaker is trying to assert the connection with food access and the food desert in the city of New York. Okay. Let's move ahead. So our objectives here are to explore the access, identify the gaps, and to create a metric for this scoring. For food bank operations, food insecurity and hunger itself is a global crisis, and food banks serve as a critical intervention to this problem. And 1 out of 6 people have actually visited the food bank, and they generally use this 3 echelon structure to serve the food insecure households. And we work with Food Bank of Central and Eastern North Carolina, which work in 34 counties, 600 agencies, and these are the census tracts that in the service area. The public transit infrastructure in the service area are sparse and mostly concentrated in the urban areas. As you can see in the Raleigh, Durham, Chapel Hill, the triangle area, the web-like features, only about 20 transit agencies. And to define access, we rely on the number of agencies that can be accessed within a travel time. Similar for public transportation, say we have a census tract, we have this route, and we have all these agencies down the line, and we use a total travel time to consider this accessible. And for data, we use agency data from food bank, geospatial data from census. The GTFS data provides us the routes and food insecurity from Feeding America, and the classification is from the Department of Agriculture. So we first map out all the agencies, the routes and everything. Then we focus on the demand of the area and the supply from the agency and take all of this into the structure of the accessibility scoring. Let's talk about coverage. Say we have a census tract that has both an agency and a route. We have one with a stop, one with only an agency, one with no coverage at all. If we map all these out, only the urban areas are covered by both. Then the rest of these now focus on the red ones, which are no coverage. They have the highest in number. They have the highest population and food insecurity as well. The urban areas are somewhat evenly distributed among the four groups, not so much in the rural areas, mostly uncovered. We use this as this for a scoring. We have an agency, all these food insecure population inside this travel time threshold. We calculate the ratio based on this, the travel time. Say we have a census tract that we want to score this from, and we consider all these agencies within the threshold and use this to score the access for that census tract. We are already familiar with this. These are the urban areas, the rural areas now. And if we just compare this with the drive accessibility, we do see that the urban areas are not so accessible here. The darker it is, the more accessible it is. On the contrary, the rural areas are more accessible. Why is it this? Because the urban areas have high food insecurity, but low threshold around 15 and high drive time. It is completely opposite for the rural areas here. And if you see the public transit accessibility is highly concentrated here. For the Raleigh area is and only the city centers are accessible, not so much for the other ones, but not every urban areas are the same. We do have the smaller Greenville town, which has a stronger transit, thus more accessible. The urban areas are actually the least accessible. We can see in the least quarter, the first quartile here. They are dominated by the urban census tracts here. And we go beyond this access and try to find the agencies that serve as the sole source of food support for the whole area. And we found that these are mostly in the urban areas with high food insecurity and in the coastal areas, which are prone to natural disaster. So our key takeaways is that on the contrary to our beliefs, urban areas were actually generally less accessible and also more vulnerable to disruptions. I'm open to any questions. Thank you.
Thank you very much, Rishik. We have time for one question.
Okay.
And we have a question from the audience from Carla Tejada. This is a very interesting topic. Thank you for your presentation. I wonder if you have any data on what is the portion of the population living in food deserts that are actually served by food banks. How many are or could be served by regular markets? And if the price of food is the only driver for people to choose to get food at a food bank?
Okay, interesting question. So the first part, yes, we do know that actually how many people live in these areas. We do have the food insecurity data from these census tracts, so we can actually identify this. And the second part is that the regular market and the price of the food, that's not what we have been doing in this part, but it's an interesting question. So the connection in between the regular groceries and the food support. So the access has been, I mean, the work in access has been mostly done in the context of the regular groceries, but we are trying to do this on the context of the food support. But it is an interesting topic to combine both the food support and the regular groceries and try to see and overlay the access of both here.
Thank you very much. Thanks for the question and for the answer. We'll move forward with our next participant. we have Enoch Onsu. Enoch, please go ahead and unmute yourself. I'll give you access in a moment. Enoch is a PhD candidate at North Carolina A&T State University, and his research relates to evaluating and improving food distribution equity in food bank networks utilizing inequality measures such as the Gini Index and Hoover Index for equitable strategies in the fight against food insecurity. And I'm giving you access now, so the floor is all yours.
Thank you. So I'm presenting on leveraging inequality measures for equitable food bank operations, a data-driven approach. I'm from North Carolina A&T State University. So food insecurity is basically defined as the consistent lack of access to sufficient food resources to sustain an active, healthy lifestyle for every member of a household. And statistics shows its prevalence. For example, there's about 47 million people in the United States that are food insecure. And in the fight against this food insecurity, we have food banks bridging the gap, supplying surplus food to food insecure people. So basically, we have this how the network looks like. We have donors giving to food banks giving to charitable agencies, and then beneficiaries going for food from those agencies. And as part of their operations, they are faced with challenges categorized into equity as to how they can share food fairly, effectiveness, whether they are meeting demand, and the nutritional value of the food, efficiency with regards to logistics, costs, transportation, and stuff like that. So for my work, I'm centered focused on equity. And current system uses the fair share analysis, which basically measures need against allocation to know which counties are overserved or underserved. And what I'm trying to do is to employ a tested and established inequality measures like the Gini and Hoover indices to see if they can also tell different stories with regards to equity. So I use data from the Food Bank of Central East and Eastern North Carolina, and they have about 6 branches. Or the map basically shows their service regions. And for the data, I focus on the meals per person in need values, and I draw emphasis on the total pounds of food distributed for this particular presentation. So the Gini index basically measures the deviation from perfect equity by summing the absolute pairwise differences of MPIN values among all counties within a branch. And higher Gini values indicate greater disparities. And the Hoover measures the differences as against the average MPIN. And that also establishes the proportion of resources that needs to be redistributed to achieve equity. And for the analysis, I look at it from the network level where I sum up all the counties over different time periods. And I look at it from the branch level as shown in the map, earlier map. So this map shows a quick snapshot of areas that are record high inequalities. So the dark blues are areas that record high inequalities with regards to MPIN values. And this one shows for Hoover, which records areas that need redistribution. So the dark one shows areas that need high redistribution to achieve equity. And these are the numbers that align with the map I've shown earlier. So For example, we see here shared county. Basically, shared counties are counties that are served by different branches, like primary branches, like Raleigh, Durham, and all of that. And we see that those counties record the highest Gini indexes to suggest that the NPM values for those counties vary largely. And a county like New Bern records very low Gini, which suggests that distribution within that branch is quite equitable. And on my right hand is the Hoover index, which suggests the redistribution aligned with the level of disparities as the Gini shows. And this is the network level trend, which basically shows how the Gini is recorded over time, and we see that from 2020 going, like the index actually is a little substantial, which suggests probably to corridors. Yeah. And for this, I'm trying to show the complementary advantage of the Gini to the fair share system that's already in practice. So the fair share tells counties that are overserved, which is in green, and underserved in red, and to what degree. So these ones can establish whether a county is overserved or underserved, but the Gini then can
I'm sorry,
tell.
Anna. You're at the 5-minute mark, so please wrap up.
Thank you. The Gini can tell actual disparities that exist within that branch and not just establish how far or close they are to meeting their needs. So that's what this research has been able to achieve. Thank you. Any questions?
Thank you. Thank you, Anna. Yes. While we have these slides here, we can get a quick question from the audience. So I do have a question for you. It seems a little counterintuitive for me that it is the shared counties, the ones that show the highest disparity according to Gini and Hoover. So I was wondering if you have an insight as to why would the shared ones be the ones that have the lowest equitable distribution?
Not particularly, but then we can think of it as, because it's being served by different primary branches, the idea would be that there might be some overlooks with regards to whether they are being met, or like who is really serving how much and stuff like that. So like that disconnect as to data and information with regards to whatever they are getting can play a major role. Who are they really being served by? Raleigh, is Durham really meeting the needs or something of that sort? Yeah.
Okay, thank you very much. Thank you, Anak, and
Sure.
we'll move forward to our next presenter. We have Jianan Shu. Jianan, please go ahead and unmute
Yes.
yourself while I introduce you. Jianan is a PhD candidate at the University of Maryland, and his research is related to marketplace analytics, service operations, and AI for social good. So, Jianan, we are all yours.
Okay. 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 Oh, hi everyone. My name is Jianan, and today I'm super excited to share our recent work on AI self-preferencing algorithmic hiring. So let's get started. Okay. Okay. So we know actually AI is reshaping the hiring landscape, and it's clear that it's clear to see this trend from recent news. So while AI can make hiring more efficient, it also introduces new challenges about fairness and equity in hiring practices. So in fact, half of the companies are now leveraging AI technology in their hiring pipelines. And while we have become aware that large language models can perpetuate racial, gender, and age biases, a new form of bias recently emerged in practice, which is AI self-preference bias. It is the tendency of an algorithm to favor its own outputs over human or other AI-generated contents. Therefore, in this study, we would like to rigorously examine this new phenomenon and ask the following research questions. First, does AI exhibit self-preferencing behavior in hearing decisions? And second, if so, how prevalent is this self-preferencing bias across different major large language models? And finally, after establishing the existence of the bias, what are the mitigation strategies and how effective are them? To answer these research questions, we leveraged a large-scale resume data set, which is widely adopted by AI researchers. The data is collected prior to the era of large language models and expand across different occupations. So we first mathematically formulate AI self-preferencing bias. Then we carefully design a resume audit experiment to help us identify this new form of bias in algorithmic hearing. And finally, we propose several effective mitigation strategies to reduce this bias in hearing practices. Okay, so here's how we define self-preference bias. It can be two layers. On one hand, we have LLM versus human self-preference bias, which is the tendency of algorithm to prefer content generated by itself over human written content. On the other hand, we have LLM versus LM self-preference. In other words, it captures the tendency of a model to prefer content generated by itself over content generated by alternative models. We operationalize these two layers of bias using common fairness metrics, such as statistical parity and equal opportunity. Statistical parity self-preference captures the overall tendency of an AI model to prefer content generated, while for equal opportunity, it checks whether this self-preference still persists after we control the content quality. So with that in mind, we carefully design a resume corresponding experiment where we first remove the human written summary from the original resume, and we ask different major language models to generate a new summary based on the rest of the content. So to this end, we get a counterfactual resume. It is AI generated, but have all of the other elements identical to the original resume. So what we are going to do next? So here we ask LLMs as the resume evaluators. Basically, each of the model will be presented with a pair of resume, the original one and the counterfactual resume. Then we ask the LLM to choose which one is better. And in this process, we specifically control the original bias by counterbalancing the order of these two resumes. So what we find is actually quite striking. The LLM versus human self-preference bias is substantial and pervasive across major large language models, with a magnitude ranging from 68% to 92%. And this bias still persists even after we control the content quality through human annotations. Moreover, the LLM versus LLM self-preference bias exists, but it's a little bit less pronounced compared to LLM versus human self-preference bias. So after establishing the existence of AI self-preference bias, what we are going to do is to propose effective mitigation strategies. First, we have system prompting, where we explicitly tell the model to ignore the differences between AI-generated content and human content ones. And second, we have majority voting, where we aggregate the evaluation from major large language models with two smaller models that do not exhibit significant self-preference bias. And what we found is that these two mitigation strategies are both effective in reducing the self-preference bias. Okay, so to conclude, our paper provides the first empirical evidence of AI self-preference bias in algorithmic hearing. And in particular, we find that LLM versus human self-preference is quite substantial and rigorous, with the magnitudes from 68% to 92% across major large language models. And finally, we propose two simple but very effective approaches to mitigate this new form of bias that we identified. So thank you, and I'll open for any question you may have.
Thank you, Janan. We will now check for questions. I have a question. What leads to an LLM exhibiting one of these biases?
Yeah, actually, because it's still like work in progress, and we are kind of doing the mechanism analysis. I think one interesting mechanism is is what we call self-recognition. It's because the LLMs can actually recognize the output they generate because of some of the syntactic and linguistic features of the generated outputs. And we are doing kind of like a simulated experiment to establish like the mechanism behind the thing.
And you mentioned the two mitigation strategies. The first one, the prompt one, are you explicitly telling the LLM to ignore or something like prefer resumes that are humanly generated or the look that were humanly generated?
Yeah. So actually, it's like it's a very simple strategy. It's like in the system prompt, we just inject a sentence that to tell the model, like if you find some clues, like the content is generated by a human, then you should not disadvantage that piece of content.
So you're asking it to not disadvantage it, right?
Yes, like that's one way to mitigate this bias, but it's kind of like quite simple. Like the idea is quite simple, but actually it's effective like for the major large language models. But as you can see, the magnitude is still like the reduced magnitude is still kind of like 40% to 60% in absolute magnitude. So if we want to like further mitigate the problem, then of course we might need to do some fine tuning like to further eliminate this AI self-preference bias.
Understood. Thank you very much.
Thank you.
Thank you. We will now move forward to our next speaker. And we have Valentina Castañeda Torres. Valentina, please unmute yourself while I introduce you. Valentina is a PhD student at the Georgia Institute of Technology, and her research is related to equitable access to healthcare and humanitarian logistics. So, Valentina, you should now have access, and we're all yours.
Okay, thank you. I'm just trying to. Okay, it works. Thank you very much. So today I will want to show our project on the assessment of primary healthcare accessibility in rural areas while considering vulnerability. First, I would like to talk about the motivation for this type of problem, and it's that first, primary healthcare or PHC is the main entry point to the healthcare system. So it's fundamental in a healthcare system, and moreover, there are 50% people that reside in rural areas worldwide, and almost 2 billion people lack access to adequate healthcare, which is relevant. And in these areas, there are multiple barriers, including geographic barriers that difficult access. And in the geographic barriers, we have, for example, lack of transportation or long distances, but also we have demographic factors such as social stratum, the culture, or the population density of each population that should be taken into account to better capture how these characteristics of these populations can affect their access to healthcare services. So based on that, we aim to answer the research questions: how can we evaluate access to primary healthcare in rural areas while incorporating the vulnerability of each population? To answer that question, we developed a PMID and facility location problem. And in this type of problem, we have a study area where we have health entities. Each health entity has a coverage area. And we want to see which points in the population have access to health services and which do not have access to health services by minimizing social costs. And social costs, in our case, encompass transportation and deprivation costs, which are related to traveling to the service points, and also terminal costs, which are related to the unmet demand of the system. So I mentioned deprivation costs, and these are the way that we propose to measure vulnerability. And deprivation costs are basically a measurement of the suffering resulting from the lack of access to essential goods or services. And this is a concept that is commonly used in humanitarian logistics, but given that they are typically calculated using deprivation time and also the characteristics of the populations, we are using it as a way of measure vulnerability in healthcare. So we followed 4 steps to calculate deprivation costs in our study area. First, we identified 4 vulnerability indicators, which were the rurality index, the road network, and the percentage of children and elderly population in each municipality that we analyzed. We then normalized those indicators, and we assigned each of these normalized indicators in a scale of, in a range of more or less 50% of the original parameters of a deprivation cost function that we use as a benchmark for our case study. And lastly, we calculated the average for these indicators so that we ended up with a deprivation cost function for each municipality. And lastly, we also calculated terminal cost that I mentioned as the cost related to the unmet demand as the deprivation cost of most vulnerable populations after 120 hours. We used this information to make a case study in a rural region in Colombia called Nariño, where more than 50% of the population lives in rural areas, and we found that 22% of the populations do not have access to health services. Among those who do have access, 20% were assigned to a different municipality, to a health service point outside of the municipality. And also we found that terminal costs encompass almost all of the costs of the system. So we saw that the model was not sensitive to transportation and deprivation costs, and that led us to do a scenario analysis by modifying the terminal point, which is the 120 hours that I mentioned before. So we changed that value to calculate new terminal costs ranging from 1 to 10 hours. And in this graph, you can see bars as costs and red line as the number of municipalities with access. So from TP's terminal points from 1 to 4 hours, we see a trade-off between between transportation and deprivation costs with terminal costs. At 5 hours, we saw that we reached the maximum number of municipalities with access. And from that point on, we saw an increase in terminal costs while the results remained the same. So we were more interested in seeing how this trade-off worked between costs. And that's what we graphed here. We have lines, and each line represents transportation and deprivation costs for the most and least vulnerable municipalities. And we also graph terminal costs, and also in the dotted line, we have the threshold of travel time. And we found that, for example, here first, we see that the intersection between terminal and deprivation and transportation costs occur around 2 hours. And in that point, then that means that access is granted if that happens before the intersection. And we also see that as the time passes, the difference between populations becomes clearer. So we see the vulnerability differences. And lastly, we saw that if the intersection happens after the travel threshold that we defined, the model becomes completely driven by terminal costs. Lastly, I would like to mention that while previous work has focused on geographic barriers, we are the first ones to include deprivation costs as a measure to, as a way to measure vulnerability to better capture the vulnerabilities of the population. Thank you.
Thank you, Valentina. And we have time for a quick question.
I'll ask a question so that you don't have to ask a question, Sophia, given that you are
Thank
not here. It seems that, well, the most important things here is like two things, like deprivation and the terminal cost. But the deprivation factor is, if I understood correctly, is a factor of the terminal cost too as well, right? Is the deprivation after the 120 hours? Is that?
Yeah, that's true. That's how we define terminal cost. That terminal cost was defined based on the deprivation cost function.
Right. So, and the deprivation cost function, this is like a very, like a Russian doll kind of question, depends on the proportion of children and the proportion of elderly. What is the weight for these two populations, and why these two populations and not something like disabled or veterans or people with horrible streets?
We actually use 4 indicators to calculate deprivation cost functions. So we use, as I mentioned, the rurality index, the length of the road network, and also the percentage of children and elderly. We use those indicators because we found in the literature that those were factors that were previously used to define vulnerability. And we didn't use more factors because we faced a lack of information, especially in these areas. So we work basically with what we could find.
But how do you decide the importance among these 4 factors?
We assign the same weight to everyone. Yeah, so each factor weighted the same.
I see. Okay. Well, thank you.
Thank you.
Thank you very much. Thank you, Valentina. We will now move forward to our next speaker. 1 second. Yes, there you go. Wanling Yang. Wanling, please go ahead and unmute yourself while I introduce you. Wanling is a PhD candidate in the University of Rochester, and his research is related to studying customer strategic behavior under innovative technologies in service operations. So, Guangling, you should have access now, and the floor is yours.
Let me try. Okay, it works. Okay, thank you. Good morning, everybody. My name is Guanling Yang. Today, I'll be presenting on the topic of information disclosure policies for omnichannel services with invisible customers. And this is joint work with Ricky Rugreen. Not long ago, ordering food meant going to a counter, and seeing a doctor meant going to clinic. Thanks to technology, our world today is omnichannel. We can now order McDonald's on an app, see doctors through telemedicine, but this convenience has a new problem, a new digital divide. Take McDonald's as an example. Think about it. You have the online customer, is often tech savvy, has a smartphone and data access, getting real-time updates. But the walk-in customer may lack digital access, be less tech savvy, or simply need to be there in person. Here's the critical issue. All those online orders are invisible to the walk-in. This isn't just an inconvenience, it's an information inequity. One group has better information to make decisions, potentially leading to better outcomes, and the group with less information can disproportionately include lower-income individuals, seniors, and those with disabilities. To understand the impact of this information inequity, we use a game theoretical queuing model. First, we model the status quo, which we call the online advantage system. This is what we see in most places today. Walk-in can only see the physical line, while online users get accurate wait time estimates, giving them a clear advantage. But can we design a fair system? Some businesses are trying. You may have seen digital screens in store showing all pending orders. This represents our second model, the For Information System. It's a technology-driven policy where everyone, both walk-in and online user, gets the full picture. This sets up our core research question. Is for information equity always better? Specifically, when does promoting informational fairness actually improve overall user satisfaction and social welfare? Actually, it's not that simple. It depends. Our research shows that it comes down to two key factors. First, how much customer value the service, and second, the percentage of walk-in customer. These two factors created a strategic map, and when we plotted the major food chain on this map, we found they naturally landed in different places, suggesting there are no single best policy. Here, we mapped out when each information system is better for social welfare. The results are striking. First, for the services where convenience is the key and customer value is relatively low, like in the fast food industry. Information inequity actually can help improve the social welfare. But for essential services where the value of care is very high, like a community clinic, telemedicine could harm the very people it's meant to help. In this case, our results are clear. Information equity is critical. The takeaways is powerful. The optimal policy isn't universal. What works for the fast food can backfire for healthcare. So to conclude, what are the key takeaways from this research? First, we must recognize that information invisibility in our increasingly digital world is an equity issue with real consequences for digitally underserved population. Second, our most pressing finding is that information inequity can paradoxically improve social welfare in certain situations. So more information isn't always the answer. And this leads to our final point. Context is critical. There's no one-size-fits-all policy to design truly effective and fair systems. We have to understand the specific context of the service and the community it serves. And that's it. I'm welcome to any questions if you have any.
Thank you, Wanling. We now have time for a couple of questions.
I would like to go first. Well done, Wenli. I enjoy your presentation. As you were talking about this idea of information equity, the notion of full observability versus partial observability came to mind. Did you all explore like partial information equity? It's still inequity, but not as much inequity, I suppose. Or is full observability necessary for this type of settings?
So yes, so in our model, since we use the game theoretic model, right? The information we refers to is the sort of the queue length or the wait time you have to have. So in our original papers, we have 3 different models, which is no information at all for all customers and partial information for walk-in customers and full information for online customers. And we have this full information model, which is we provide full information to everybody. So we do have different types of model we explore. And then in our original papers, we do provide this disclosure policies when it comes to different industry, different contexts.
Okay, got it. Thank you.
I have a question. Could you explain a little bit more? How do you define social welfare?
Yes.
Or how did you measure it?
Okay, so the social welfare in different industry, of course, in different academia, differently. So commonly in the OM literature, the social welfare is defined as the surplus of customers. For example, if you just you have the service reward after service completion, you have to minus your waiting cost or hassle cost, and that surplus equals to an individual's customer utility, and then we have to integrate and congregate all of customers' utility, and that is the social welfare.
And you had data for all of the industries that you showed to be able to measure social welfare in the different industries?
So in that map that I show, there's a 2 index, right? The x-axis represent how customer value your service. And we use the Google review, the weighted Google review to approximate that number. And for the y-axis is the walk-in percentage. We usually will get it from the annual report from the companies.
Understood. Thank you very much.
Thank you.
And we will now move forward with our last speaker of the day. We have Kimia Jusani. Kimia, please go ahead and unmute yourself. Kimia is a PhD student at Sharif University. And
I'm at Virginia Tech.
Incoming, yes, I got confused. Incoming to Virginia Tech or already in Virginia Tech? I'm sorry. And
Yes,
then yes, in Virginia Tech.
Please go ahead. Sorry.
Yes, I apologize. I got confused. And then Kimia's research is related to healthcare as a fundamental human right and looking at optimal and fair health resource allocation. So with that, Kimia, I'm going to give you access and you should have it now and the floor is all yours.
Thank you so much. Thank you so much for having me here. I'm gonna today present my research on proactive and fair epidemic resource allocation through an integrated supply chain framework. And I present some insights from a COVID-19 case study. So upon 4 premises, I created this research that epidemics are responsible for 14 to 20% of deaths in 21st century, which is significant. The underserved populations have a dramatically higher death rate, 15 times more likely to pass away from COVID-19, according to the data that we had, even in the US. And vaccines are one of the most effective ways to prevent epidemics from happening, basically from endemics to becoming pandemics. And if we cannot solve access to healthcare, which is a very broader problem, we can at least allocate vaccines, which are preventive measures, better to improve the well-being of the society. And there was even the vaccines are liquid gold. There was a 10 to 20% vaccine wastage during COVID-19. Upon these observations, I am defining these three questions. How can we integrate the epidemiological dynamics with supply chain and fairness to have more efficient ways of allocation to prevent the high death rate in the vulnerable population, as well as preventing the vaccine wastage? And how can such formulation be implemented in reality? And if so, how are the results compared to current frameworks that we have? So this is an integrated framework. As you can see, we have the SVIR model, which is a compartmental model, susceptible, vaccinated, infected, and removed population. And we are integrated with PI-GD, which is the supply and distribution, and administration, which is the demand. And what we are doing is we are integrating these models that are classically separated from each other. So we are using operations research as a solution methodology to solve this problem and find an optimal solution for a very large scale problem with thousands of variables and constraints. We want to, at the same time, achieve three main objectives. First, we want to minimize the total number of cases that occur during the period that we are allocating the vaccines. We want to also maximize the state lower bound of the vaccines as a definition of equity. And we want to also, in two ways, either minimize the Gini coefficient or maximize the knapsack formulation that we define as a new definition of equity, which I will get to very quickly. So our main constraints are epidemic simulation, dynamic decision-making, supply chain, and equity. So we define a new definition of equity. We derive some metrics based on the infection, population, and social vulnerability index for each county within the US, multiplied by the access to healthcare. And then we define a knapsack-based problem, normalized, that multiplies these weights by the number of vaccines allocated to each county to come up with a maximization problem for equity. This is very more efficient based on our results compared to Gini coefficient. However, still, we couldn't solve the entire problem in 120,000 seconds for the entire US, so it's very untractable. In order to tackle this problem, we come up with these two spatiotemporal decomposition algorithms that, if chosen properly, they will produce 0.04% optimality gap under 4 seconds, where the actual problem can be solved in thousands of seconds. So our algorithm is improving the solution complexity by thousands of times. So this table presents the sensitivity of our model to selection of the weights, which are the equity, efficiency, balance. If chosen properly, we can save 2 million infections from happening in only 6 months, with 3% death mortality rate at the time that we did the case study, which is the beginning from the December 2020 to May 2021. 60,000 people could be saved only with better allocation of resources. And if we multiply that by that 15 times more likely, we could have saved 300,000 vulnerable people from dying. How is it important? We are showing that equity not only is good for social welfare, of course, it helps efficiency of the model. Basically, if we are helping the more vulnerable population, we are saving the society from cost, which is caused by the lack of access to vaccines, which will cause to severe cases, hospitalization, and death. Also, we will help the GDP, prevent the GDP from decreasing significantly, because although the vulnerable population are not often seen, they are fundamental drivers of the economics within the society. This map that you can see shows how...
I'm sorry, you're at the 5-minute mark?
Okay, sure. Thank you. So should I continue?
Just wrap up, please.
Okay, sure. So this map shows how states are over-allocated and under-allocated. So the very, very brief problem is that California needs more vaccine, Texas has more vaccines, Ohio has more vaccines, Pennsylvania has less vaccines. So if we just share these resources, we will be able to save at least 5 million infections from happening in 6 months. Thank you so much for your attention, and please ask any questions.
Thank you, Kimia. We have time for a very quick question. I will quickly, actually, no, never mind. I will quickly ask, I forgot what was the question that I was going to ask you. Oh, your model is deterministic, right? Or are you able to capture any disruptions or any changes in the system as they happen?
So basically for now, we are using a deterministic but time series based infection rate to capture the other things that are happening in our environments, for instance, distancing or lockdowns that we are not capturing at the moment. And we are studying the demand, which is estimated based on the data of vaccine hesitancy as an upper bound. So for now, our model is deterministic because we wanted to make sure that we can solve a stochastic problem. The next step in the next paper, we are solving the stochastic model, which is kind of possible thanks to our decomposition algorithm that solves the problem under 5 seconds. And that's the next step, basically.
Thank you very much.
Thank you. Yeah.
And with that, I would like to thank everyone for joining us today, our participants for your wonderful presentations. You're all doing amazing research, so please keep it up and good luck as you continue to move forward in your PhD studies. And to all of our attendees who joined us today, I would like to invite you again to please scan our QR code, the QR code that you see in the screen. Again, this will take you to a form that will allow you to provide feedback to all of our presenters today, and will also allow you to provide feedback to the organization of this event. We will be judging all of these presentations throughout the summer, and the winner will be announced during our MIF business meeting and the next Informs annual meeting that will happen in October 2026 in Atlanta. So please, for all of you, make sure that you join us during our business meeting and hear the announcement of who's the winner of today's competition. So with that, we can end today's session. Again, thank you very much. I'm just going to continue to leave this screen sharing here, but you're all welcome to log off. Thank you again.
Thank you.
Thank you.
Thank you.